Hi friends, I am Dr. B.V. Rao of Usha Clinic and founder of the website qmedicaldoubts.blogspot.in and raghavamedicaldoubts.com. Through these videos, I am providing the basic knowledge about the commonly occurring diseases, treatment and surgery details when necessary, for medical knowledge to general people and for reference to medicals. Today I am going to discuss about the thyroid, exophthalmos, Hashimoto's thyroiditis, goiter, etc. Thyroid gland consists of isthmus and two lobes. It lies in front and on either side of the upper part of the trachea and laminae of thyroid cartilage. Posteriorly, it is related to recurrent laryngeal nerve which lies between the trachea and esophagus. It is separated from the nerve by a sheath. Blood supply. Rich blood supply by superior and inferior thyroid arteries. The parathyroid glands are present on the posterior aspect of thyroid in its substance or in the sheath of the gland. The hormones secreted are thyroxine and thyroiodothyroxine, triiodothyroxine. T3. Thyroid secretions are controlled by thyroid stimulating hormone TSH, secreted by the anterior pituitary gland, which in turn controlled by the thyrotrophin releasing hormone TRH, secreted by the hypothalamus. Calcitonin is another hormone. Exophthalmos. It is usually present in persons with hyperthyroidism with stimulation from the pituitary gland. It is defined as the protrusion of one or both eyeballs, detected clinically by appearance of the white sclera both above and below the iris. In some cases, the periorbital edema frequently present obscure this sign. The progression or regression is recorded by the exophthalmometer. Exposure of iris may result to keratitis, producing a feeling of gut and excessive watering. The conjunctiva may become infected and edematous, chemosis. Weakness of the extraocular muscles may give rise to an exophthalmoplegia with double vision, which is often first detected when the patient is asked to look up and outwards. In rare cases, the progression may cause increased intraorbital pressure, cause a severe aching eyes and reduction in visual acuity. In this case, a relief of pressure within the orbit is achieved to avoid permanent deterioration in vision. It is achieved surgically by orbital decompression. If surgery is not feasible immediately, large doses of oral steroids may be used. Fortunately, it is usually less severe and after progression enters into prolonged phase of improvement, but eyes never come to the normal state. Lateral tarsorrhaphy, a surgery to prevent exposure keratitis and to improve the look by stitching together of the outer margins of eyelids. In mild cases, antibiotic eye drops and protective glasses prevent the irritation of glare, dust and wind. The hypothyroidism secondary to thyrotoxicosis, as it may aggravate the exophthalmos. In some cases, exophthalmos may precede the thyrotoxicosis and present a problem of diagnosis when it is unilateral. Thyroid function tests may explain the diagnosis. Hashimoto's thyroiditis. It occurs most commonly in middle-aged women. It is a firm, diffuse enlargement of the thyroid gland with or without hypothyroidism, associated with pain in the neck and mild obstructive symptoms. Diagnosis. Antibodies in the serum to the thyroglobulin or to the microsomal fraction of thyroid cytoplasm, usually in high titer. ESR is often elevated. Needle biopsy confirms the diagnosis. Histologically, gland consists of small thyroid vesicles with a columnar epithelium showing eosinophilic granularity. Infiltration by lymphocytes and plasma cells, sometimes with the germinal center formation and an increase in fibrous tissue stroma. Treatment. In most cases, there is a regression in size of the goiter in response to the thyroxine 0.2 milligrams a day. It is hastened by 20 milligrams of prednisolone 8 hourly for 10 days. The patient should be on continuous treatment with thyroxine, though not hypothyroid previously. Subacute thyroiditis. QUERVAIN'S thyroiditis. It is slight enlargement of the thyroid and is painful. It is thought to be due to virus infection by Coxsackie B virus. Viral studies are not always positive. Thyroid function is suppressed, confirmed by low uptake of radioactive iodine or technetium by gland and histologically show giant cells. ESR is elevated. Thyroid antibody tests are negative. The condition tends to regress spontaneously but may be protracted. Treatment. Thyroxine 0.2 to 0.3 milligrams a day should be given to suppress TSH secretion, and in some cases oral corticosteroid or parenteral ACTH may be necessary. Dysharmogenesis. The patient who has a partial enzyme defect related to one of the steps in the synthesis of thyroid hormone is likely to develop a goiter in response to continued TSH secretion in the attempt to overcome the enzyme block. Bruit may be produced due to the increased vascularity. The commonest and easiest to detect is a genetically determined defect in the binding of iodine to tyrosine, which, when associated with nerve deafness, is known as Pendred syndrome. Diagnosis. It can be detected by a test with potassium perchlorate following an oral tracer dose of 131 iodine or 132 iodine potassium perchlorate, discharging out the gland any iodine which is not originally bound. Carcinoma of thyroid gland. The occurrence is rare. When present, may be anaplastic or differentiated, follicular, papillary, or mixture of two. Advanced cases, the gland is hard, irregular adhesions to surrounding tissues and associated lymphadenopathy. Early carcinoma presents as a single nodule having more function than the surrounding normal tissue. Diagnosis. If the nodule is large, detectable as a cold area on thyroid scanning. In case of single nodule, it is difficult to distinguish malignancy from the benign clinically. So it is always removed for histological examination. Treatment. A well-differentiated tumor must be treated by total thyroidectomy followed by oral thyroxine 0.2 to 0.3 milligrams a day for life. Occasionally, metastasis from the well-differentiated tumor may take the sufficient radioactive iodine after all normally functioning thyroid tissue has been ablated by surgery and 131 iodine to allow effective treatment with a further large dose of 131 iodine. Anaplastic tumors may show good initial response to external radiotherapy but invariably recur. Medullary carcinoma. Medullary carcinoma of thyroid arising from the parafollicular C cells is of particular interest as it is associated with high levels of calcitonin, prostaglandins or 5-hydroxytryptamine. These cause symptoms flushing, barborygmy and diarrhea. Patients with this form of cancer may have neuromas and other defects. Benign solitary lesions. Adenomas or cysts, calcification in the cyst is common. Hemorrhage is occasionally occurs into adenomas and on these grounds as well as other their removal is justified. Simple goiter. It is a soft enlargement of the thyroid gland. It is sporadic but in certain parts of the world it may be found frequently and is referred to as endemic goiter. Etiology. It is related to the deficiency of iodine, may be deficiency in diet or because of factors in diet or water such as excess calcium that may interfere with iodine absorption or because of goitrogens in the diet that prevent concentration of iodine by thyroid. Fish is the main source of iodine. So simple goiter is endemic in mountains of New Guinea, Alps and in Himalayas. The drugs like sulfonamides, PAS, iodine in large doses as in cough mixtures etc. An intermittent shortage and supply of iodine to the gland over the prolonged period result in multinodular goiter. Other causes may be patchy defect of colloidal storage throughout the gland. The incidence can be reduced by using iodized oil or salt. Clinical features. Small diffuse simple goiter may occur at puberty or pregnancy and may regress spontaneously but sometimes may persist. If already present, may enlarge further at this time. A simple goiter of long duration may achieve considerable size, become nodular and give rise to obstruction symptoms, especially if there is a retrosternal extension. Compression or deviation of the trachea may be noted clinically or radiologically, and obstruction in the thoracic inlet may lead to may be noted clinically, radiologically. Obstruction in the thoracic inlet may lead to venous engorgement of the head and neck. Treatment. The treatment of sporadic simple goiter at puberty is thyroxine for 1 or 2 years, not potassium iodide because of the risk of iodism. An adequate intake of iodine should be ensured. Multinodular simple goiters are unlikely to respond to thyroxine and may require partial thyroidectomy for cosmetic reasons, or if obstructive symptoms are present or likely to occur. Post-operative lifelong treatment with thyroxine may prevent recurrence, though hypothyroidism after partial thyroidectomy for simple goiter is uncommon. Prevention. An adequate intake of iodine in early years of life is the only way to preventing this condition. Calcitonin. The parafollicular cells, C cells of the thyroid gland secrete a polypeptide hormone calcitonin, apparently unrelated to other functions of the gland. When administered by injection, it lowers the serum calcium concentration. Its main effect on bones is inhibit resorption, so that in these two important respects it could be regarded as a physiological antagonist of parathyroid hormone. It is secreted in large quantity by the medullary carcinoma of the thyroid without producing significant hypocalcemia. And after complete removal of the source of the hormone, the thyroid gland, hypercalcemia is not the fact. Therapeutically, the hormone has been used in some success to reduce hypercalcemia, but it is not necessarily the most effective method of doing so. In hypercalcemia associated with many malignant diseases, treatment with the steroids is to be preferred. In Paget's disease of bone, it is to be preferred. In Paget's disease of bone, it has proved valuable in providing relief of pain in monitoring of cases where pain is a dominant feature. Daily injection of a period of 6 weeks followed by relief of many months, then repeated if necessary. That's all about the thyroiditis exophthalmos. And in the next video I will discuss about some other disease. Thank you.